Next will be Dr. Jennifer Goldman, who will be presenting on Lewy body dementia and is going to review the latest clinical characterization and diagnosis and the scientific research that's happening in this area, including the deep importance and the relationship that particular related dementia has with Alzheimer's disease. There's a interesting scientific interaction between those two diseases. Jennifer?
Great. Thank you. Can you hear me okay?
Yes.
Perfect. Okay. And thank you so much for the opportunity to present today. My background is as a movement disorders neurologist with specialty certification and interest in behavioral neurology and neuropsychiatry. And over the years, much of my work has focused on the RD, the related dementia of Lewy body dementia. These are my disclosures. Oh, next slide, please. There you go. These are my disclosures. And then next slide. This is the outline of what I'll cover today for this session. As Dr. Bateman said, I'll talk a bit about the terminology and clinical features, epidemiology and impact, cover a bit of highlights on the science, and turn towards the ADRD research recommendations, resources and programs, and important considerations for governmental agencies, and of course, some of why we are all here convening today. Next slide, please. Okay. While this may not be new to everyone in the audience, I always think it's really important to make sure that we're on the same page regarding terminology. And in my experience over the years, this terminology can be confusing even to people in neurology and other related disciplines. So it's worth spending a moment on this. The umbrella of Lewy body dementia refers to the clinical syndromes and indicates both Parkinson's disease dementia and dementia with Lewy bodies. The pathology, as we talk about it, is typically what's referred to as Lewy body disease. And we'll talk more about the underlying pathology and advances in our understanding of biology with being able to identify Lewy bodies and neuronal loss on pathology from brain autopsy specimens, and now moving into the era where we can detect these as assays in life. The pathology encompasses several different parts of the brain, predominantly in the brainstem, but also other areas in the limbic regions and parts of the neocortex of the brain. As you can see in the bottom right-hand panel, microscopic image of what a Lewy body looks like, and on other stains, and then of course regions in the brain. Next slide, please. Okay, so just a little bit regarding the epidemiology of both dementia with Lewy bodies and Parkinson's disease dementia. So DLB, and I'll go a little bit with abbreviations for DLB and PDD today. So DLB is cited as the second most frequent neurodegenerative dementia after Alzheimer's. It's thought to affect about 1.4 million people in the United States. And as you can see, the incidence and prevalence rates listed here, it represents about 4 to 30% of dementia cases in the population and clinic-based studies. Parkinson's disease itself, without the dementia component of it, affects about 10 million people worldwide, with recent studies showing that about 90,000 people are diagnosed every year with Parkinson's in the United States. We know that some people, but not all, with Parkinson's will go on to develop dementia or mild cognitive impairment. And from these studies, it suggests that the incidence of dementia in Parkinson's, or PDD, is about 100 per 1,000 patient years. And that is about 10% of a Parkinson's population developing dementia per year. As I said, not everyone with Parkinson's develops dementia, but it's thought that about 30% of people do have a point prevalence of PDD. And then as time goes by, more and more years with the disease, there's a higher risk of converting to dementia with a cumulative prevalence of about 75 to 80%. Also, just on epidemiology, it's generally thought that both of the Lewy body dementias affect men greater than women, but there's a great need to understand more about sex differences. There's some studies suggesting that these differences in sex may dictate different types of clinical symptomatology. And as I think we've recognized in other presentations, there's much more that we need to understand about racial and ethnic differences in the Lewy body dementias. We're starting to see some of these studies emerge, but again, as already pointed out, many of our clinical trials are based on white and Caucasian populations. So next slide. Okay. So the impact of Lewy body dementia, probably well known to many of you in the audience, is truly great. So there are many aspects that Lewy body dementia impacts. And one in particular to highlight is the delayed or misdiagnosis of Lewy body dementia. So this may be partly due to its myriad of clinical symptoms. So from cognitive changes to behavioral elements like depression or anxiety or psychosis, to Parkinsonian mood symptoms, autonomic dysfunction, sleep disturbances, and others, there's often a delay in the diagnosis or a misdiagnosis, particularly for DLB. And that may also, the types of symptoms may influence what type of specialist is seen first. So not everyone might see a dementia specialist first, or even a Parkinson movement disorder physician. So on average, it has been said that it takes about 18 months and 3 doctors to receive the correct diagnosis. And in my clinical work over the past 20 years, I have definitely been, for some the first, but in many cases, the 5th or 6th or 7th neurologist people have seen to be diagnosed with dementia with Lewy bodies or Lewy body dementia. It is well recognized that Lewy body dementia has a great impact on function, with functional impairment, increased disability, and decreased quality of life, not only for the person living with Lewy body dementia, but also their care partners and families. Many of these symptoms can be highly problematic, and some have likened having LBD to both Alzheimer's plus Parkinson's at the same time due to the profound nature of cognitive and motor issues. There's a high economic burden that has been detailed, and then much about caregiver stress and caregiver burden associated with Lewy body dementia. And then lastly, there are substantial management challenges. And we'll talk about a little bit this in light of current research, but due to limited medications to treat the various symptoms, the side effects of some of the medications, so some medicines that might treat psychosis can worsen motor function. Others are marked with profound sensitivity to the medications that is unique to Lewy body dementias. And at present, there are no disease-modifying therapies at this juncture, although there's great interest as we learn about what is happening in the Alzheimer's field. There's one drug approved for PD dementia in the United States, rivastigmine, one drug for PD psychosis in the United States, namely pimavanserin, and one drug for DLB specifically in Japan, and that is donepezil. Next slide. Okay, so these are the criteria by which DLB and PDD are diagnosed. I'm not going to go through these, but just to mention that there are core clinical features that highlight the presence of dementia and related important clinical symptoms like fluctuations in cognition, hallucinations, REM sleep behavior disorder, where people may act out their dreams at night when they're supposed to be sleeping, as well as Parkinsonian motor features like tremor, slowness, trouble with gait and balance, and so forth. The DLB criteria have gone through several iterations, with the last published criteria in 2017. And as you can see, these criteria not only include core clinical features, but biomarkers that can be indicative or supportive to the diagnosis. And I think to highlight this, this mirrors the evolution of the Lewy body dementia field looking at what's been happening in the Alzheimer field and the incorporation of biomarkers into criteria and biological definitions. So just as a reminder for the Lewy body dementias, both DLB and PDD share many clinical features, although the time course may differ such that the dementia occurs first in DLB and typically motor symptoms occur first in PDD. And as we'll see, they share many aspects, but not necessarily all of underlying pathology and biology. Next, please. Next slide. Oh, thanks. That's great. Just to highlight the biomarkers in the DLB criteria, you can see two boxes that have blue outlines around them. And in the top panel on the left, you can see an MRI brain scan showing the relative preservation of the medial temporal lobe in DLB compared to Alzheimer's. And on the bottom, you can see what's an abnormal dopamine transporter scan showing decreased uptake in DLB compared to looking normal in Alzheimer's and healthy controls. And the DAT scan has now been FDA approved for diagnosis of DLB in the past year. On the right side, you can see a cardiac scan that's been used in some centers, demonstrating changes or abnormal presynaptic uptake in DLB, but not so in Alzheimer's and healthy controls. Next. So the pathology of Lewy body dementia is quite complex, but a hallmark of the pathology has been the presence of alpha-synuclein in Lewy bodies and Lewy neurites in several regions in the brain, including the brainstem, but also the limbic and neocortical regions. However, there may be a presence of Alzheimer's pathology with deposition of amyloid beta and tau in the brains of people who were clinically diagnosed with Lewy body dementia. And as we're seeing, there are more studies that highlight the contributions of co-pathologies or mixed pathologies in autopsies. And I think this point is particularly important as we talk about potential disease-modifying therapies that have been approved for Alzheimer's and more that may be on the horizon. So as Dr. Head asked the question, what does this mean for people with Down syndrome? We ask a similar question, what does this mean for people living with Lewy body dementia? Some studies have shown that about 2/3 or more of DLB cases may have Alzheimer pathology at autopsy, and approximately about 1/3 of Parkinson's disease dementia cases may also have Alzheimer pathology. There may be contributors from cerebrovascular disease and even TDP-43. And so I think this co-occurrence or mix of pathology will be incredibly important for us to understand, not only from clinical trial perspective, enrollment criteria, the effects of disease-modifying therapies on different underlying biologies, but some studies suggest that it may actually influence the clinical phenotype and progression of Lewy body dementias in terms of the frequency and severity of memory deficits or motor features or REM sleep behavior disorder. Next slide. So less is understood regarding the genetics of Lewy body dementia compared to Alzheimer's and Parkinson's per se. And most Lewy body dementia cases are not likely genetic, but some genes are thought to be involved or implicated. And you can see those highlighted in the bold text, whether GBA, MAPT, ApoE, and synuclein. And for some of these, like GBA, these mutations may be associated with greater neuropsychiatric symptoms. And as we're starting to see in the Parkinson's field, there are pharmaceutical companies and interventions targeting these different gene mutations. So perhaps there will be lessons learned from the GBA trials in Parkinson's that will be applicable as well. Research has shown that not only are genes involved, but we're learning a lot more about what are called epigenetics. And these are factors as to how behaviors and environment can cause changes in the ways the genes work and influence the genes. Next slide, please. Okay, so next I'll turn towards the 2022 NAPA ADRD Summit research recommendations. I won't read all of them on this list, but please take a look. There are 8 recommendations, and I'll touch on several of these in particular. As you can see, research recommendations numbers 1 through 4 focus primarily on clinical characterization and intervention, and recommendations 5 through 8 focus primarily on pathogenesis and mechanisms of toxicity. Next slide, please. So the top priority and recommendation from the ADRD 2022 summit, and actually several prior summits occurring before that, has been to prepare for and initiate clinical trials that aim to alleviate or slow the course of Lewy body dementia symptoms and delay or prevent the onset of disease. So in recent years, there have been growing numbers of Lewy body dementia trials, although several, particularly in the past few years, have unfortunately been met with negative outcomes or failure to meet their primary endpoints that were designated in their clinical trials. We'll talk a little bit more about some reasons why that may be. In this slide, you can see a snapshot from clinicaltrials.gov as of last week. There are several trials currently recruiting or starting to recruit that are looking at different drug compounds and targets for Lewy body dementia symptoms, along with a few trials to understand the roles of different biomarkers and imaging scans. So the field is active. I always think there's been a lot that's occurred over the past time that I've been in this field, but there is clearly a need for clinical trials to have better, effective, and safe symptomatic therapies, and certainly disease-modifying agents. Next, please. So just to go quickly through these snapshots here, because there has been a lot of work in the field, and over 20 years, as you can see in the bottom panel with the orange graph, orange bars, there has been quite an increase of numbers of trials that have been implemented from 2002 to 2022. And there was a time when we didn't have trials to offer our patients, and now we do. And I think that in and of itself is great progress, but still more to go. So you can see in this slide, these trials indicate both disease-modifying therapies and symptomatic therapeutics that cross a wide array of targets, looking at metabolism, different neurotransmitters, oxidative stress, synaptic plasticity, and a number of different modalities. They also need to tackle a variety of clinical symptoms. So people with Lewy body dementia don't just have one clinical symptom. They have a whole host of clinical symptoms, from dementia to psychosis to apathy to depression to sleep dysfunction to motor Parkinsonism. And those all may need to be addressed. There are trials spanning all phases from phase 1, 2, and 3. And as you can see, there has been growth and progress over the years. Next slide, please. One of the challenges in Lewy body dementia trials, not only in terms of diagnosis and enrollment, and whether trials include people with both Parkinson's disease dementia and dementia with Lewy bodies, or one group separately, has been that most of the trials have used scales that were developed for Alzheimer's. And we recognize that not all dementia is Alzheimer's, and there are differences between Lewy body dementia and Alzheimer's, even if there may be overlapping pathology in some. And so this slide just illustrates that there have been several efforts in recent years to identify and or develop clinical trial outcome measures that are specific for Lewy body dementia, ones that focus on the key cognitive and other clinical features of Lewy body dementia, and not necessarily key features that are salient for Alzheimer's disease. These measures also need to be sensitive to interventions and, of course, change over time. And one tricky problem in Lewy body dementia are cognitive fluctuations. So where people may be alert or have differences in their arousal or attention during the course of hours to days to weeks. And this can be a confounder in clinical trials and measurement. So there are a number of groups working on this, and there's still much more to come in terms of understanding outcome measures, not only from clinometric and research basis, but also from the perspective of people living with Lewy body dementia and what is important to them. So next slide, please. Okay, so this slide just illustrates the drug development and clinical trials in Parkinson's disease. So not necessarily Parkinson's disease dementia, but all of Parkinson's, with an update over 2023. And as you can see, there are many different compounds in the pipeline being tested for symptomatic therapeutics or disease modifying therapies. The majority still focus on motor symptoms, but here you can see a growing list of trials that have looked at the important non-motor symptoms, including cognition associated with Parkinson's. Okay, moving to the next slide. So the research recommendation number 2 is geared to develop and refine neuroimaging biomarkers that track progression, assist in differential diagnosis, provide therapeutic target engagement, and relate to pathology. And a number of imaging modalities have been explored over the years, including structural MRI, specialized sequences, functional MRI, and nuclear medicine or metabolic imaging, as you can see listed here. Several have identified key attributes to Lewy body dementia, and in particular, dementia with Lewy body disease, dementia with Lewy bodies, looking at regional metabolic changes or the cingulate island sign or reduced dopamine transporter uptake. Interestingly, the presence of amyloid beta deposition on scans has been variable, and not surprisingly with the pathologies that we see, but there are gaps and needs and I think opportunities for us to understand some of these imaging modalities in dementia with Lewy bodies. So such as dopamine transporter scan results in DLB, such that not everyone may have Parkinsonian features. There is a need for imaging that looks at and can detect alpha-synuclein, as well as other important neurochemicals like the cholinergic and noradrenergic systems in Lewy body dementia. Next slide, please. So the third recommendation focuses on biomarkers. And I think this is an area where we have seen some very important progress, particularly in the past year, and several notable publications in 2022 and 2023, and a few that are slated for release, I believe, this week. So we will hear about biomarkers in some of the other presentations, but one of the highlights includes the detection of the protein alpha-synuclein, which composes the Lewy bodies in vivo. So in life, being able to detect alpha-synuclein in spinal fluid or skin tissue. And so one of those discoveries this year has included what's called the synuclein seeding assay, or SAA, particularly in cerebrospinal fluid. And here are just several studies that have looked at the SAA test in cerebrospinal fluid, including the Parkinson Progressive Marker Initiative and other cohorts. And this assay was able to detect Parkinson's with high sensitivity and specificity, and to differentiate it from other atypical Parkinsonian syndromes like multiple system atrophy. A Swedish group in the BioFinder study looked at this assay in a memory clinic. So these are not people diagnosed with Parkinson's. These are not people diagnosed with dementia with Lewy bodies. And they found the assay to be positive, detecting alpha-synuclein in about a quarter, with only about 21% of those fulfilling clinical diagnosis for Lewy body dementia. They also noted that among those who had synuclein, almost half of them also had Alzheimer pathology. So there's much more coming up in this area, and there's soon to be 2 published biological definitions and staging systems for neuronal alpha-synuclein disease as related to synuclein, neurodegenerative markers, and imaging scans and other genetic subtypes. And this type of biological definition, as applied to Parkinson's disease dementia, Parkinson's disease, and dementia with Lewy bodies mirrors the evolution of the Alzheimer field, with the emphasis on its underlying biology and advances in our techniques to be able to measure protein changes in life and ultimately to have disease-modifying therapies. Next slide, please. And so this ability to detect alpha-synuclein in life, and with assays such as cerebrospinal fluid or skin biopsy, and potentially down the road in blood, opens up new opportunities and new windows to see what the underlying biology of people who may be at risk for the disease may have. So there are implications for what we call prodromal cohorts. So these are two examples. One is the PPMI, Parkinson's Progressive Markers Initiative study, and the other, the Swedish BioFinder study. And what they found was that the SAA test was done in people who have prodromal or high-risk symptoms to develop synucleinopathies, namely REM sleep behavior disorder and decreased or loss of smell, called hyposmia. And they found that the majority of those people were positive for synuclein on the SAA test, meaning that they would be able to look at their development of Parkinson's or Lewy body dementia over time. From the Swedish group, they found the SAA test was positive in about 8% of cognitively unimpaired individual, and its presence was associated with the development or conversion to Parkinson's or dementia with Lewy bodies over time. And so I think these open up the possibilities of being able to identify participants for clinical trials of disease-modifying therapies, and of course, much more to understand about the implications and applications of these. Next slide. So recommendation 4 focuses on existing and developing new longitudinal Lewy body dementia study cohorts. And I'm just going to highlight 2 cohorts here that have been ongoing. One is the North American Prodromal Synucleinopathy, or NAPS Consortium, which looks at people with diagnosed REM sleep behavior disorder, or the acting out of their dreams, to prepare for clinical trials and develop biomarkers of these synucleinopathies. The other is the PPMI study that I've mentioned a few times already, and this involves an ongoing and evolving study of de novo Parkinson's, which are people who are newly diagnosed or untreated, and those with prodromal features like REM sleep behavior disorder or hyposmia, positive dopamine transporter scans, or genetic risk variants. And these are longitudinal studies. They will also help with clinical trial readiness and are important aspects for this recommendation. Next slide. As Dr. Bateman said, in short, it takes a global village. So there's much research being done around the world in Lewy body dementia. This paper depicts the global reach across Europe, North and South America, Asia, and Australia that include longitudinal and other cohorts. And I would just like to highlight the NIH-funded Dementia Lewy Body Consortium and the ADC NAC data programs that fill great need and promote research. There's still important needs and gaps for increasing the sharing of data across sites and cohorts and learning across global diversity for Lewy body dementia. Next slide, please. Here are several key resources and programs highlighting the NIH programs for NIA and NINDS, along with other federal programs. And the Lewy body dementia community has really become a global community. So you can see there are LBD advocacy groups across the world, including the United States Lewy Body Dementia Association, which is now in its 20th year. And these are not only research resources, but also education, awareness, and advocacy resources for people living with Lewy body dementia. Next slide. Okay. All right. And lastly, but very importantly, there are considerations for government agencies for clinical care and research. There may be many others, but this slide depicts several considerations that are worth mention. For clinical care, These include greater support for improving diagnoses, access to care and specialists, which we already heard about, and that goes for Lewy body dementia as well, coverage for tests for diagnoses, including dopamine transporter scans, other biomarker assays. There's still a substantial delay in getting accurate diagnosis and at early stages. There's a considerable wait time for specialists and knowledge gaps, as we already heard, for those who might not be specializing in these particular dementias, as long as opportunities for increasing awareness and resources available. There are further needs to assist patients and their families to reduce disability and disease burden and enhance quality of life through looking at different types of care models, access to care and treatment options across all stages. It's important to look at the early prodromal stages and follow people longitudinally, especially as these disease-modifying therapies become available. But not only that, it's also important to have this for our transparency and communication with patients and their families, for planning, prognostication, and helping people to be able to live to their best abilities and quality of life. On the research side, to highlight a few needs and considerations, although there's been growth, there's continuing need to advance clinical trials for symptomatic therapies that are effective and safe, and disease-modifying agents. There's needs regarding study design and outcome measures that are relevant and specific for Lewy body dementia, as well as improving access to clinical trials and making trials that are as minimizing or as much burden as possible. We need to understand specific symptoms of Lewy body dementia that are unique to this population, and particularly as we start thinking about early interventions. And of course, further research on biomarkers, genetics, mechanisms, and models. And with that, I will close and appreciate your attention for today. Thank you.
Okay, fantastic. Thank you, Dr. Goldman. We have a question here in the room. Helen?
Thank you, Dr. Goldman. That was incredibly comprehensive. What I'd like to do is actually more of comments. Most people here in the room know I have 3 first-degree relatives who have succumbed to the disease. So to say I'm at risk is an understatement. But what I wanted to do is just highlight the fact that, yes, over the last few years, understanding the genetics behind this disease is just coming to the forefront. We've just had windows into GBA and SNCA and the others, MAPT. And what I want to do is just purely endorse the reality that there are more genetic studies out there. I personally have a test kit waiting at home to go back to the University of Miami. I've got one that was just shipped 6 weeks ago to go to the NIH. So there are studies out there that people need to raise their hands for and get involved in. The other thing I'd like to highlight is on an international scale, through the iStart program, the professional interest area in the Alzheimer's Association, there is a wonderful Lewy body dementia PIA. And they've put out some wonderful work on recognizing where the gaps are globally, what there is available globally, and then other research institutions can take that and move forward in developing programming and research. And then the last thing is January 28th, for the first time ever, the international group of all of those smaller Lewy body dementia agencies have banded together, and for the first time ever, January 28th is designated as the International Day of Lewy body dementia to raise awareness globally. So thank you.
Okay, fantastic. And Dr. Goldman, I have one brief question for you. In terms of the diagnostic modalities for Lewy body dementia, you mentioned that there were several, both PET scans and now a CSF test for alpha-synuclein seeding. Is that clinically available? And the reason I ask is that as we are doing spinal taps for people with Alzheimer's disease to identify who has amyloid plaques, you pointed out the prevalence of amyloid plaques in Lewy body dementia is about 40 to 60%. It seems to me that a high percent of our patients likely have some Lewy body dementia that could be captured at diagnosis so that we could track in a registry how they do over time with treatment of removing amyloid. So are there clinically available tests for Lewy body dementia that are specific and accurate?
Yeah, that's a great question and really spot on for where people are thinking in the field. For a very, very long time, they were really only research based. There is now some commercialization and companies that offer what's a test that will look at the synuclein in the cerebrospinal fluid. And so I think that will change the landscape as this becomes more and more commercially available and also incorporated into various research studies and clinical trial protocols. And I think, of course, we would all like less invasive markers over time. And I know there's work being done on various blood markers, but adding it to cerebrospinal fluid profiles, if you're already assaying for Alzheimer markers, may have both research and clinical utility. Thank you.
Okay, fantastic. Thanks. So maybe the recommendation for those of us in practice now is to have a research study to store the samples so that in the future when we have clinical tests or research tests available, we can go back in a nested study and answer those questions and not lose the opportunity. We're at time, but I'm gonna take a minute just because Dr. Quieres has raised her flag. You have a question or comment?
Question. I'm going to be quick. A great presentation. I was just wondering if you know if there are ethno-racial differences in the clinical presentation on LVD or if that's like an area of research.
Yeah, great question, and still an area that needs much more attention. There actually was a few publications coming out in recent times that looked at some of the racial and ethnic differences in Lewy body dementias. I think some of it based on the NAC database as well. And a few pearls from that review indicated that there's later diagnoses for non-white participants, greater other comorbidities like diabetes, hypertension, cerebrovascular risk factors in Black and Hispanic populations. But really, this is an area that is kind of begging for research and is pretty wide open in the field. So I think more to come, hopefully in the future on that.
Okay. All right, thanks. We're going to move on now. Dr. Brad Beauvais has kindly recorded his talk on frontotemporal lobar degeneration. He's currently actually live in another meeting, and so he's virtually in this meeting, and he's figured out how to clone his presentations. So we're set. We'll go ahead and play that.
Hi, my name is Brad Beauvais. I appreciate the opportunity to provide an update on progress in frontotemporal lobar degeneration. I do regret not being present in person, but hope this is informative. These are my disclosures, and none of these are pertinent for this talk. This is the outline I'd like to try to cover. First, go over the complex terminology in FTD, FTLD, then review the epidemiology, then the impact of the disorder on individuals, families, and society, then turn to how the diagnosis is made in the clinic, then review the syndromes, pathologies, and genetics, then turn towards the recommendations for FTLD according to the most recent summit in 2022, and focus on the progress and gaps on these recommendations, and then close with resources and programs and considerations for governmental agencies. So first, terminology, and even for those of us who do this for a living, the terminology is quite complicated and hard to keep straight at times. The frontotemporal dementias, or FTD, refers to the umbrella of clinical syndromes with behavioral variant frontotemporal dementia, or BVFTD, being the prototype, and then primary progressive aphasia, or PPA, being also encompassed under FTD. There are two variants that are particularly relevant, and I'll come back to that in a moment. Frontotemporal lobar degeneration, or FTLD, refers to the spectrum of pathologies associated with prominent frontal and or temporal dysfunction that can manifest clinically as FTD, PP, and other disorders. And there are a number of primary proteinopathies, as they're called, that are under this FTLD umbrella. The two most common proteinopathies are related to tau, or TDP-43, and sometimes the terms tauopathies and TDP-opathies or TDP-43-opathies are used. Epidemiology, and most of this data relates to behavioral variant FTD. The incidence is about 1 to 8 per 100,000 person years, so this is relatively uncommon. The prevalence is, depending on the population studied, 2 to 20 per 100,000. And the incidence and prevalence increases with age, plateaus around age 70. But importantly, the incidence and prevalence is about the same as Alzheimer's disease in those who develop symptoms before the age of 60. And importantly, the FTDs often manifest in early or middle age, so 30s, 40s, 50s, 60s, therefore prime of life, and just underscoring the devastation that FTD can cause. There doesn't appear to be any clear sex predilection, and most of the data that we have on FTD, FTLD is in white population. It does not seem to be common in non-white populations, and it's unclear whether this is a bias of individuals coming to the clinic or being involved in research studies, or if there are biologic differences or other factors, or some combination of these. And the importance of studying FTD in underrepresented minorities is viewed very important. The consequences of altered behavior and cognition are pretty obvious. Again, this tends to happen in individuals who are in their working years. It leads to fractured relationships with family members and friends, divorce, poor job performance, loss of one's job and the effect on income, medical insurance and pension, sexual indiscretion, gambling, excessive spending, sometimes orders of tens or hundreds of thousands of dollars. Financial devastation is not rare, and sometimes tragic accidents happen. And importantly, many of these things happen prior to a diagnosis is even made. So a lot of the symptoms related to FTD are thought to be midlife crisis or a primary psychiatric disorder, and it can take 1, 2, 3 years, sometimes longer, before an appreciation of a neurologically based disorder. The costs are significant. They're at least double that reported for individuals with Alzheimer's disease. And in one study, caregivers rated the quality of life of their loved ones with BVFTD as worse than dead, and underscoring the, again, devastation of this illness. How is a diagnosis made in the clinic? Again, it's typically delayed before individuals are seen by clinicians who are knowledgeable in FTD, but it's based on the clinical features, neuropsychological profile, imaging features, and absence of other explanations, especially on laboratory testing. And the key consensus criteria for BVFTD and PP are shown at the bottom, but the core features of BVFTD include disinhibition, apathy, loss of empathy and sympathy, perceptive, stereotype, compulsive, ritualistic behavior, hyperorality or dietary changes, And then on neuropsychological testing, the deficits in attention and executive functioning are obvious. And then imaging, as shown at the bottom, whether by MRI or fluorodeoxyglucose positron emission tomography or FDG PET, one can see the predominance of atrophy in the frontal regions, in hypometabolism in the frontotemporal regions. Contrast that with primary progressive aphasia, which is a predominantly language disorder, and this is what's seen on neuropsychological testing as well. Imaging, it depends on the variant, and there's 3 variants under the PPA umbrella, 2 of them classically associated with FTLD. So in the semantic variant PPA, this is a problem with coming up with the names of people and nouns and loss of word meaning. And on MRI scan, so by convention, this is the left side of a scan, one sees atrophy of the left temporal lobe. And on FDG PET, you can see the obvious hypometabolism in the left temporal lobe. Contrast that with the non-fluent variant of PPA. This is a disorder of speech and language production. And so the frontal opercular region is affected, and that can be seen on FDG PET. MRI scans, it can be pretty subtle. This individual, you can see the perisylvian atrophy, but in a lot of individuals, the MRI looks more normal than not. So nuclear medicine studies can be helpful. But this is how a clinical diagnosis is typically made. The clinical syndromes are varied, and they can be confusing. The next set of slides were developed by the Association for Frontotemporal Degeneration, and this shows ALS can be considered under FTLD, mixed FTD ALS, behavioral variant FTD, and semantic variant, and non-fluent variant PPA as well. Logopenic variant primary progressive aphasia is often not considered under the FTLD rubric, but is here for completeness, corticobasal syndrome, and progressive supranuclear palsy as well. And the clinical aspects are shown on this figure. The syndromes can relate to the pathology. They clearly relate to the topography of pathology, but the protein, dysfunctional protein, is not one-to-one in most of these syndromes. In ALS, FTD ALS, and semantic variant PPA, usually there's underlying TDP43 pathology. Non-fluent PPA and corticobasal syndrome PSP is more often tau pathology. Behavioral variant FTD is roughly 50-50, tau versus TDP43. Logopenic PPA is often due to underlying Alzheimer's disease. And genetics are important in FTD. About 20 to 40% of cases are associated with variants or mutations in a known FTLD gene. There are dozens now known to be associated with FTD and or ALS, and just some of those are shown here. And there are what are called the big 3 of FTD, chromosome 9, open reading frame 72, microtubule-associated protein tau, or granulin or progranulin. Those are the 3 most common. And there is somewhat of a relationship of certain genes with the syndrome, but if there is a genetically mediated disorder suspected, it is worthwhile doing a panel to investigate because of the variability and non-one-to-one correlations in a lot of these syndromes. These are the 8 most recent recommendations by the NAPA ADRD Summit. Again, this was from 2022. I won't go through all of these, and the underlying is my own emphasis of these 8 recommendations. 4 of these largely relate to clinical science. 4 of these largely relate to basic science, and I'll highlight some of these in the next set of slides. Recommendation 1, priority 1, so this is viewed as the top research recommendation to better understand FTD, epidemiology, and genetics in diverse populations, including how socioeconomic and ethnocultural status affects disease risk and the manifestations. And on the left-hand panel, this is data that was accessed earlier this week from the National Alzheimer Coordinating Center, the main database for Alzheimer's and related disorders research. And this may be a little bit difficult to see, but the FTLD syndromes that are recruited into the ADRC network are shown on the left here. This is the frequency of these syndromes among non-whites and the frequency of Hispanics that have any of these syndromes. Clearly, these frequencies are not consistent with the population frequencies in the United States. And again, this is a high priority to understand, is this a sampling bias, biologic reason, other factors, or some combination? And then if one looks at the genetic causes of FTLD, they do span most of the countries where this has been investigated, again, with C9orf72, MAPT or tau, and granulin being the most common. There are regional differences likely due to founder effects, but genetic FTD is pretty global, at least in the countries in which it's been investigated. Recommendation 2 is focused on developing an array of FTD biomarkers for diagnosis, prediction, disease monitoring, target engagement, and patient stratification for clinical trials. And I think it's fairly safe to say that the current reasonably established measures and biomarkers for diagnosis and tracking include the clinical dementia rating scale plus the 2 domains in the NAC FTLD module, as it's called. This is an 8-domain scale. It's pretty widely used in clinical trials nowadays in FTD, as well as neuropsychological measures, biometric MRI, and there's a lot of data now on plasma neurofilament light chain, or NFL. And in this a recent publication that involved North American groups as well as European groups, all pooled and then looked at these markers as they relate to C9orf72 mutation carriers compared to granulin, compared to MAP-tau. While the focus of the MRI region on which volumetrics were done and which specific neuropsychological test was assessed, one can see that there are changes in the pre-symptomatic phase. So 0 for each of these represents symptom onset. So some of these biomarkers are changing years prior to symptom onset, and then they evolve in a relatively predictable manner afterwards. And if one then uses this data to plan for clinical trials, this does look daunting. So depending on which measures are used and over what time period, this top panel shows what the power calculations for each arm would be required for a prevention trial to be adequate, and a symptomatic trial is shown on the bottom. And if you focus in on the bolded numbers, these are more reasonable for any clinical trial, but it will require a combination of measures to realistically have one or more treatment trials in these various genetic populations. We still do not have, this is really important, we still do not have any good biomarker for the primary tauopathies or the primary TDP-43 opathies. However, there is encouraging work that is been published over the past few years. And this is data from the Washington University group looking at a marker for the 4-repeat specific tau. This is a MTBR. And this panel shows an increased amount of insoluble 4-repeat tau in brain regions in the 4-repeat tauopathies. The CSF values are decreased in many of these same disorders. Contrast that with a recent publication using a seeding assay for TDP-43, so basically an RT-QuIC type assay, And this is from an Italian group showing the measurement of TDP43 versus non-TDP3 based on seeding of frontal cortex, and then to do this in the olfactory mucosa. And so this set of data, as well as the previous one, encouraging, but obviously needs replication to see if these look even more promising. So we still have some major gaps. Again, no blood or spinal fluid or PET marker that clearly identifies primary tau disorder versus primary TDP disorder, although some recent data is encouraging. Other than neurofilament light chain or MRI or FDG PET, these all track pretty well with as disease progression markers, but they are non-specific markers, and one ideally would like a more specific protein focused marker. We don't have any well-established ligands for PET for 4-repeat or 3-repeat predominant tau. 4-repeat tau is in most of the tauopathies. 3-repeat tau refers to Pick's disease, defined pathologically. And we don't have a PET ligand for TDP. This is a very active area of research in many countries to identify these ligands, but nothing available as yet. Recommendation 3 focused on treatment and developing novel treatment trials. This may be a little bit hard to read, but this is a publication already a little bit dated, despite it being published a couple of years ago, showing the trials that have been completed and unfortunately are negative or in progress for progranulin mutation carriers, the C9orf72 expansion, the tauopathies, and then symptomatic treatment trials here. We still have 0 FDA-approved treatments for FTD or FTLD, but many clinical trials are in progress, in addition to several more that are not shown here that have begun since that publication in 2022. So again, a lot of activity in this area, fortunately. Priority 4, identifying overlapping pathogenic mechanisms between FTD and the other neurodegenerative disorders and syndromes. There's a lot of data now that what was initially thought with TDP43, it may be specific for FTLD, but one can see TDP43 pathology in those who have Alzheimer's or Lewy body disease or vascular dementia. So we don't have a good explanation for that. AD pathology may co-occur in those with typical FTLD pathology, and even Lewy body disease pathology can occur with some frequency in progranulin mutation carriers. So these, the pathophysiologic and clinical significance of these and other associations are not yet clear. Recommendation 5, this relates to preclinical and translational tools and resources. There are many that are being built. This is just one example of a comprehensive resource of induced pluripotent stem cells from patients with primary tauopathies. And so anyone interested in accessing these samples, this is a key report, but there are other resources that can be found in various websites. Recommendation 8, an important one, to define the genetic and molecular modifiers of FTD, including, again, in diverse populations. And in contrast to familial Alzheimer's disease, familial ALS, where the individual age of onset is relatively similar to the parental or familial age of onset for that mutation, it's much more variable in the FTLDs, especially for progranulin and C9orf72. Tau, it's a little bit tighter, but it's still not very good correlations. And so defining markers of age of onset, rate of progression, and the phenotype is very important and still not well understood. However, there is progress being made. We have known for some time that there's a protective haplotype on a different gene known as TMEM106B. This is associated with decreased penetrance and a later age of onset in those with granulin and C9 mutation carriers. It's also associated with a reduced TDP43 burden in brain in those with TDP pathology. And it's also associated with slow progression in those with TDP pathology who don't have typical FTLD pathology uniformly. And so we've known about this, and that's just a sampling of association studies, but we haven't understood the mechanism. And the bottom figure and citation was just published yesterday, and this may provide insights into the mechanism. So we've known now over the past few years the protein TMEM106B does deposit in brain. This is based on cryo-EM studies, and it now looks like that the core accumulation that relates to this blue as shown on this schematic here is a central mechanism to neurodegeneration, and the protective haplotype reduces that core accumulation and therefore may explain these clinical and pathologic associations. So much more work to be done here, but a very nice insight just published. But we still need to find the additional markers for predicting symptom onset, penetrance, eventual phenotype. Again, C9orf72, one can have an FTD phenotype or ALS phenotype or mixed, and we don't know why that variable phenotypes evolve. And we still don't have a good sense for the rate of progression in most of the sporadic and familial FTLDs. What about exercise or physical activity? This is a summary of two recent papers that looked at this, and there is an association between increased physical activity and cognitive activity and decreased longitudinal clinical burden in genetically mediated FTLD. That's the data shown on the left. And a follow-up study looking at the neurofilament light chain. So typically as clinical burden increases, the NFL level increases as well. But as one is more physically active, the NFL increase is attenuated, and therefore exercise may slow down the rate of progression or neurodegeneration. At least that's the interpretation of these data. So we promote physical activity and cognitive activity with all of our patients and families, and there is data to support that. Turning to resources and programs, strong support from NIA and NIDS. Again, we're very grateful. And with the NAPA plan, viewing this as a high priority focus. One can see a number of other good resources and programs, NINDS information on FTD, information on the ADRC network across the United States. A lot of FTD spectrum patients are recruited and followed through the ADRC network. The main repositories of clinical data, biofluid data and samples, and imaging data at these respective sites. There are numerous clinical trials posted on clinicaltrials.gov focus on FTD. The core patient organizations, the Association for Frontotemporal Degeneration has been around for 20 years, very strong in support, education, awareness, and research in the FTDs, and also the Frontotemporal Dementia Disorders Registry. This is a global effort now with thousands of people worldwide registered with an FTD spectrum disorder. And then a brief mention on some of the key natural history study programs. The All-FTD program is the primary natural history study in North America with 28 sites following sporadic and familial FTD. The GenFI program is largely in Europe. That's focused on familial FTD and also very successful. And then the Frontotemporal Dementia Prevention Initiative is the global effort on these genetically mediated families with a number of treatment trials being planned through that program too. Finally, some considerations for governmental agencies. First, several on the clinical side. This is a devastating illness, and it's a challenge for patients and family members to just manage things in the home, trying to get home health care, trying to get the coverage for this, trying to get respite care for caregivers. It is a challenge. And when a person may be viewed best to move into a skilled care facility, some, because of the behaviors, are kicked out. And then what do patients and families do? And it's a really frustratingly common situation without many good avenues. And so trying to promote the quality of life for patients and families while also keeping expenses reasonable and affordable. The coverage of tests to aid in the diagnosis. FDG PET is used quite commonly in clinical practice, and that can be a challenge to get that covered. It is fortunately covered via Medicare. We anticipate more and more novel blood and CSF markers, and hopefully those will be covered. And we also anticipate, as what we've seen, the enormous benefit that amyloid PET imaging has done for the Alzheimer's field. We anticipate protein-specific PET ligands will be developed, and hopefully those will eventually obtain coverage as well. Another issue that a lot of our patients and families experience is the delays in getting Social Security disability. And this is much better now than 5-10 years ago, but still some individuals with a clear diagnosis, all the documentation provided, it can be a year or more before they can start obtaining disability benefits. Many of our members of families with known or suspected mutation also share concerns, and these are very appropriate concerns, is will GINA and other policies that minimize the risk of genetic non-disclosure, hopefully that will never be altered, and if anything, hopefully even more protection will be afforded to these patients and families. Many of our patients also who want to start a family, they're asymptomatic, but they know they carry a mutation. Some of them have chosen not to know their mutation status, but the technology now exists so that pre-implantation genetic testing and IVF can be done to essentially almost guarantee that any offspring will not carry a mutation that either parent may carry. Unfortunately, very few health plans cover this, and this is often on the order of tens of thousands of dollars per family. And it's really unfortunate when there's valid attempts to essentially assure that offspring will not carry a mutation and the benefits for that individual, as well as the financial benefits long-term. The upfront coverage for this procedure is just not viewed sufficiently justified, and so this is almost always denied. And so any support for any of these clinical considerations would be really helpful for patients and families. And really, from a research standpoint, this has been viewed high priority by NAPA and the AD-ADRD portfolio. Hopefully that prioritization will be maintained, perhaps even enhanced. I'll close there. Thank you again for attention. I again regret my absence, but I hope that my colleagues who are present can try to answer any questions that may arise. Thank you again.
Okay, there is a question or comment from the room. Helen?
I'm sorry, sound isn't coming through.
Been a tech day. Can you guys hear me now?
Yes.
Okay, sorry. So Randy, you mentioned like saving the cerebral spinal fluid of people who are getting lecanemab in your center so that it can be used for Lewy body research. And it seems like from a coordination perspective, there should be some research studies that are looking holistically at the impact of lecanemab on these related dementias over time because they co-occur so much. So I know Richard and Walter are not online, but I don't know if anyone in the room could speak to whether that is in the plan or if that's something that the research community has considered coordinating on. So you can have a more holistic look at how all of these pathologies change with this treatment. Rod's there. Go ahead, Rod.
Hey, I just wanted to reiterate that what Walter said, and that is that the NINDS has plans for clinical trials that are for VCID together with beta amyloid for the passive immunotherapy, of course, as well as Lewy body dementia together with beta amyloid. And in those trials, I think certainly our expectation is that saving those types of samples is something that would make complete sense. And we would anticipate that's what will happen.
I will just say in our clinical program at Indiana University, we are separately consenting patients for collection of samples for research, and we're banking those. So I think a lot of places are trying to do something similar.
Okay, well, let's see. So I'll just make a comment, and I'm going to pass the mic back to Dr. Donna Wilcock to present. The comment, perhaps, though, is that with Brad Beauvais' presentation on FTLD, it's complex. There's a lot of different mechanisms, proteins, but I think he highlighted one really important thing, which is without accurate biomarkers, it's been really difficult to impossible to describe the disease, the course, to get a handle on it, prevalence estimates, and to make headway in terms of treatments. And this is something that with Alzheimer's disease we experienced, where once we had the ability to track the disease, our treatment development really accelerated. We really got a handle on it and could have an impact. So I think this is a lesson for all the other related dementias and perhaps even other neurological diseases, that being able to track the disease is really an essential ingredient in doing this. And it's one of these promises that's Brad covered all the different proteins and all the molecular mechanisms that are just now being understood. And so it's right there within a few years' reach. Probably there will be biomarkers if research continues and accelerates in these areas. And by having that comprehensive picture of what an individual has, what pathologies they have, whether it's pure Alzheimer's disease, which is less than half of Alzheimer's disease cases, or whether it's other diseases, I think will really accelerate what we're able to do for the ultimate goal of keeping people's thinking and their memory and their personalities as they have been for their lives. I mean, that is the goal. And so it's there. And so I congratulate the NIH on their prioritization of these other diseases in terms of figuring it out. And it should go forward. And with that, we have one of the world's experts to tell us about candidate Alzheimer's disease related dementia, fluid biomarkers, and their challenges and their opportunities. Before we start, you have a mic? Okay, very good. Okay, Dr. Wilcock, take it away.
All right, thank you, Dr. Bateman, and thank you for the invitation to present this work here. So while we're bringing the slides up, I was actually going to say exactly what you just said, which is the amyloid PET and then the subsequent development of CSF and plasma biomarkers in Alzheimer's is what got us to the first disease-modifying therapy. And I think if we can mirror that with the other pathologies, I think we'll be in great shape. And that's why we have to keep this momentum going of the research. We can't slow down now. It's really, it's prime time. So yeah, my name is Donna Wilcock. I'm at Indiana University. And next slide, please. I have very few disclosures, and actually none of these are really relevant to what I'm going to talk about. So I do a little bit of consulting and collaborating, and I serve as editor-in-chief of Alzheimer's and Dementia. So next slide, please. And so I always like to show this, and I call it the reductionist view, but I think a lot of us, when we start out in graduate school a few decades ago, that we were, and I'm a basic scientist by training. As a basic scientist, we were raised on this pie chart, which is most dementias are caused by Alzheimer's, and then behind that you have vascular, and behind that you have Lewy body, and then you have these other more rare forms. But it was presented to us as being very clean cut, that you either had Alzheimer's or you had vascular or you had Lewy body. And I think that's actually slowed our progress down a little bit when we were trying to work with such a simplistic view of dementia. Next slide, please. So this is actually the real picture of dementia. It's messy. Humans are messy at the best of times, and as we age, we accumulate so many of these different brain changes that ultimately lead to a clinical syndrome of dementia. And so I will say Alzheimer's disease does remain one of the most common causes of dementia. But we see so much significant overlap of those plaques and tangles with vascular changes like small vessel disease, small vessel ischemic disease, microhemorrhages, microinfarcts, even strokes and cerebral amyloid angiopathy, carotid artery stenosis, all of these things that affect how the blood feeds into the brain is going to affect how the brain functions. Overlapping with that, we know that there is a significant amount of Lewy body pathology, which you just heard about, as well as TDP-43 proteinopathy, which not only is present in a number of FTLD cases, but also more recently, we know that individuals over the age of 80 to 85 who present with an amnestic syndrome oftentimes have TDP-43 proteinopathy accumulating in their limbic regions. And this condition used to be hippocampal sclerosis of aging is what we called it. Now the term has been coined limbic predominant age-related TDP-43 encephalopathy, or LATE. We like our acronyms. You now have a new one. Actually, once you do get over 80 to 85, late becomes very prevalent in our populations. But because the symptoms are very much mimic Alzheimer's disease, the early stages of Alzheimer's disease, where short-term memory is the biggest problem, oftentimes that does get misdiagnosed as Alzheimer's disease. And so I think this highlights another critical need for biomarkers in this area. I show the graph on the right there simply because one of the, I would say, pivotal papers that a lot of us have referenced back in 1967, where we all made a statement that with age, Alzheimer's disease increases and Alzheimer's disease will continue to increase over the years. That prediction was based on this paper that the average age in that study was 75. If we look at older ages where we get into the 80s and 90s, we actually see that, yes, Alzheimer's disease does continue to increase. We continue to see plaques and tangles. But what you see increasing most precipitously is really cerebrovascular disease. And then what on this graph is hippocampal sclerosis, but that's really the TDP-43 encephalopathy. Next slide, please. So this is where we are. We are in, I think, really great shape with Alzheimer's disease. Do we need to get our blood biomarkers to be even better? I think we can. But you can see that there are a number of fluid biomarkers. You've heard about some of them today that can help us predict the plaques in the brain, and also some that are now emerging that help us predict the severity of the tau pathology in the brain. The development, I think, of these fluid biomarkers has really progressed since we've had our PET ligands, where we can actually visualize these pathologic changes in the brain. For the development of any kind of fluid biomarker, we need our ground truth. And while autopsy would be perfect and we could actually look at a piece of brain tissue and know what's happening, the sample sizes of our autopsy studies are not really high enough for us to be able to validate a lot of these biomarkers in the population. So PET ligands is the next best thing to an autopsy to allow us to see these changes in the brain. We can do quantitatively how much of the plaque or how much of the tangles is in the brain. And then based on that, we can validate our fluids. And so I'm going to show you some candidate biomarkers for TDP-43 and for the Lewy body, which you already heard about, the aggregation assay, and then also for VCID. But I think the development of these fluid biomarkers would be greatly accelerated if we had PET ligands for the alpha-synuclein, for the TDP-43, and if we had better imaging outcomes for small vessel disease. Right now we use white matter hyperintensity, which is a signature that we see on an MRI scan, and we say that if you have this pattern of white matter change, that is small vessel ischemic disease in the brain. But that's really very insensitive, especially when it comes to quantification of that. So we can see it and say, yeah, you probably have some small vessel changes, but you don't really see it progress. And in patients whose dementia progresses, the white matter disease doesn't necessarily progress. So we need to do a lot better on that. And there is an NINDS consortium that is specifically targeted towards developing better biomarkers for VCID, and that's called MARC VCID. So next slide, please. And the next slide. So first, I want to just talk a little bit about where we are at, not only with VCID, but also inflammation. I think we hear a lot about inflammation, and I think therapeutically, inflammation does have a lot of promise because all of those different pathologic changes in the brain have an associated inflammatory response that occurs to them. And so when we think about multi-etiology dementia, yes, I think we have a precision medicine approach where we can have a drug that targets a specific pathology, and then we could have multi-drug therapy if you have multiple pathologies. But inflammation and inflammatory responses occur to all of these things. And so we may actually be able to find an immune modulator that would be beneficial to multiple pathologies in the brain. And so, so we are now speaking about inflammation and vascular when we talk about the ATN criteria, you know, the amyloid, the tau, the neurodegeneration. The new research framework is going to be including inflammation and vascular. And so this is why it's so important to consider this. First of all, a lot of the genetic risk factors for Alzheimer's disease that have been identified over the last couple of decades are actually associated with the microglial cells in the brain, which are the primary inflammatory cells. So there's a lot of genetic evidence pointing us towards inflammation having a role in the risk of developing Alzheimer's disease. And then there's also already we have some evidence that there are inflammatory changes that we can detect in fluids that are reflective of Alzheimer's changes. And then on the graph on the right there, what you see is on the x-axis, so on the bottom line there, you're looking at a summary measure of Alzheimer's disease. So as you go from left to right, we're looking at more serious Alzheimer pathology in the brain. So this is as Alzheimer's progresses, we have more plaques and tangles, and that's going to be from left to right. As you go from top to bottom, you're looking at cognitive functions. So on the solid black line, you can see that as somebody's Alzheimer's progresses in their brain, you can see that the cognitive functioning is going down. And so if you then look at the the middle of the two lines there, the dashed line, that is for a given amount of Alzheimer's pathology in the brain. If you also have macroscopic infarcts in the brain, so larger kind of stroke type events, you can see that for a given amount of Alzheimer's pathology, your cognitive function is actually going to be worse. So you present with a worse clinical syndrome for a given amount of Alzheimer's pathology. And then the next line down is having both macro and micro infarcts, so larger stroke events and then very microscopic stroke events. You can see that it's kind of an additive effect. And so addressing not only the plaques and tangles, but also addressing the vascular would give us a much greater impact on the clinical syndrome of dementia. Next slide, please. The biggest challenge with vascular biomarkers is it's not a single pathology. It's really VCID is an umbrella term that encompasses many of these different pathologic events. And so the way that many of us are now thinking about vascular biomarkers is that we will have not a VCID biomarker, but we will have biomarkers of microinfarcts, we'll have biomarkers of microhemorrhages, we'll have biomarkers of cerebral amyloid angiopathy. So it will need to be biomarkers of specific vascular pathologies and not simply this umbrella VCID. And I think we're making progress in that area. Next slide, please. The biggest challenge with adding I, and actually this figure was supposed to make you all go, oh wow, because inflammation, as we learn more about inflammation in the brain, it is incredibly complex. It is not only, is it there or not there, but it's what type of inflammation is occurring. And when is that inflammation occurring? There may actually be a beneficial role of some of this activation of inflammation earlier in the disease when the brain is trying to stave off these pathologies from accumulating. But then maybe once an individual has progressed to where they now have tangles and they now have some neuronal dysfunction, that inflammation, the same inflammation, will now exacerbate the condition. And so there's still a lot more understanding that needs to happen. And we also think it may not be as easy as a single biomarker for inflammation, but we have to start somewhere. And there are a couple of promising markers that may indicate, at least when someone is symptomatic, that they have an inflammatory response that may be contributing to their cognitive progression. Next slide, please. So these are some of the potentials that you might hear about over time. I think the one that is probably the closest to a clinical application of some kind is going to be the GFAP, which is released from the astrocyte, one of two different immune cells in the brain. And we have shown, and many others have shown, including Dr. Bateman, that GFAP can be measured in the blood, and it does seem to associate with the clinical symptoms. So as someone declines cognitively, we see GFAP increase in the blood. And it also is correlated very closely with the levels of amyloid plaques. So as the levels of amyloid plaques go up in the brain, so too does GFAP in the blood. Some that may indicate more functional readouts, like the cells clearing out some of the bad pathology. I think the S-TREM2, the soluble TREM2, possibly even the TNF-alpha, may give us a better indication of what those cells might actually be doing in the brain and whether they're clearing or whether they're damaging the surrounding cells. But they're much earlier, I think, in development. Next slide, please. Some potential fluid biomarkers for VCID, and most of these are based on small vessel disease. And what we know about small vessel disease is there is some proteins like PDGFR beta, which is made by a special cell around the blood vessel called a pericyte. That's not to be confused with a parasite. It sounds very similar, especially with my English accent. And then PLGF, I'm going to talk about in a minute, looks very promising for ischemic small vessel disease. And this is a growth factor. It's called placental growth factor. Again, named for where it was first discovered, not necessarily its only function in the body. And then given the proximity of those astrocytes wrap processes around all of the blood vessels in the brain. And so it is possible, and we have some preliminary data, that GFAP might be an indicator of vascular dysfunction as well as degenerative pathology in the brain. And then NFL is something that we see go up in a lot of different neurodegenerative conditions. And Dr. Beauvais spoke about NFL in FTLD. Anytime you have damage to neurons, NFL seems to increase. But we actually also see NFL increase in response to ischemic small vessel disease. And Dr. Shashadri in San Antonio is leading the examination of NFL in our MOG VCID consortium. And next slide, please. So this is the data that we've been able to obtain for PLGF. And if you just somewhat ignore the graphs for now, but what we see is for frank vascular dementia, which means individuals who have evidence of small vessel disease on an MRI scan, and also a CDR of 1, meaning that they have a clinical dementia. We have a 0.89 diagnostic accuracy, meaning this is 89% accurate for diagnosing vascular dementia, in contrast to Alzheimer's disease or an age-matched controls. And then if we just focus on vascular cognitive impairment, which is milder than the vascular dementia. So this is a mild cognitive impairment due to ischemic small vessel disease. We can get to a 74% accuracy of that. So still we have work to do on the PLGF. But if you go to the next slide, please. In my lab, we asked what PLGF is doing in the brain. Very little is known about this protein in the brain. And we do actually see that PLGF is increased around the blood vessels in human autopsy tissue from individuals who had severe ischemic small vessel disease compared to an age-matched control in the same region, which is on the left. So much more of that brown staining is the PLGF around the blood vessels. In these same individuals, we saw that in their last blood draw before they died, the PLGF was significantly increased. And also actually the gene expression and the protein expression was increased in these brains. So PLGF does probably have some kind of pathologic role to play in small vessel disease. And that's some research that my lab is working on right now. The next slide, please. So when we think about Lewy body and late, next slide, please. We've heard about some of these already today, so I won't spend too much time on this, but RT-QuIC is really, this is the aggregation assay that we heard about a little bit earlier. And what this really does is you take a sample from a patient, and if that patient has pathologic alpha-synuclein in the spinal fluid, and it looks like we can use skin biopsies, we're hoping at some point we'll be able to use blood for this. But if that abnormal protein is present, if you then mix that abnormal protein with a normal alpha-synuclein protein and you combine that, it's what's called seeding. And so that normal protein will become abnormal if it's in the presence of the abnormal alpha-synuclein from a patient. And so if we go to the next slide, please. So this is basically what happens when you do this test is if you look at the bottom there, you take the patient sample and you mix it with normal alpha-synuclein protein, it forms this aggregate and imparts that abnormal structure to the alpha-synuclein. So then what you do is you shake it up, basically, it breaks apart, and now you have more seeds that will form those aggregates. And if you do this a number of times and you look at a signal from that, you can measure how many abnormal proteins you have. So it gives you a measure of the presence, how much was originally there to start with from the patient. But if you have CSF from someone who doesn't have any of these changes, you won't cause this aggregation. And so you'll get no signal, no matter how many times you shake this up and mix it up. So it's really, really, I think, a very promising biomarker and really an innovative way for us to be able to measure this. Next slide, please. And so this is just showing the sensitivity. So if you look at all these different diseases, Alzheimer's disease, Pick's disease, corticobasal degeneration, ALS, we don't really see any signal with any of those, and cognitively normal age matched. But if you take Parkinson's disease, all Lewy body dementia patients, you can see that we do see a significant signal in those two groups, indicating this is very, very specific to Parkinson's and Lewy body dementia. Next slide, please. So do we have biomarkers for TDP-43 proteinopathy? This is another place where I think we need to get a little innovative in how we might look for biomarkers. So there's two recent articles. One is by Dr. Rissman, who is at UCSD. And what he's doing is taking what are called exosomes. And so all of the cells in the brain and all of the cells actually in your body, the cell membrane turns over. And so you get these little like pinching off of little balls of membrane that contain little bits of fluid from inside the cell. And you can isolate these exosomes by using cell surface markers. So a microglial cell will have a different marker than an astrocyte cell on it. And so we can select exosomes that come only from astrocytes or only from microglia. And what Dr. Rissman showed was that if you take the exosomes derived from astrocytes, you can actually measure TDP-43 protein inside those. And only in cases of autopsy confirmed late did you see TDP-43 inside astrocytic exosomes. You don't see it in normal controls, and you don't see it in non-TDP-43 diseases. So this looks like it's very early stages, but I think this could be very promising for TDP-43. Next slide, please. And so this is another candidate biomarker where it actually it relies on the normal function of TDP-43. So TDP-43 normally binds to RNA, and RNA gets translated to protein. So it binds to RNA and it regulates how the RNA becomes protein. When TDP-43 is dysregulated, as it is in disease where it becomes aggregated, it affects how that RNA protein production happens. And so it turns out you can actually measure what's called a cryptic peptide, which normally wouldn't be there, but is there when TDP-43 is dysfunctional, because you start making this bad protein, this bad form of a protein. And so you can measure this bad form of a protein, and that is probably an indicator that there's some malfunctioning TDP-43 in the brain. And so just on the left here, these are genetic and sporadic ALS patients. So this isn't late, this is ALS at this point. But you can see with the genetic forms, and less so in the sporadic ALS, you can see an increase in the signal from this cryptic peptide. So we think this is probably reflective of abnormal TDP-43. Again, very early days, but very promising. Next slide, please. Okay, so how do we move these things forward? I think we've heard about precision medicine today. We've heard about multi-drug therapies and how we think that's going to be our future. In order to move us in that direction, we need sensitive and specific biomarkers that are scalable, meaning ideally blood. We need those in order to really realize this vision that we have for ultimately treating and preventing dementia. And so a really good place, we need ground truth. And I think I said this at the beginning, we need ground truth in order to really validate robustly these fluid biomarkers. So what can we do right now? We can do ante-mortem fluids. So we can take fluids from before people died, from people who have come to autopsy. And autopsy can be our ground truth of what changes are happening in the brain. Few challenges with that. And a big challenge is actually the sample size. Even if we did a national effort when we try to do this, a lot of these pathologies are more rare than plaques and tangles. And so the chances we would have a good enough sample size to do something very robust is minimal. I think developing PET ligands for TDP43 and alpha-synuclein is really the way to go on this. And as soon as we have those, we'll see a big acceleration in the development of fluid biomarkers. And they're coming. They are coming. Mouse models and human iPSC studies, I think, are a place to start understanding the relationship between some of the biomarkers like inflammation and how which one is good and which one is bad, and when should we be measuring it. I think we can improve the technologies to optimize these exosomes and how we isolate them and measure them. And if we do that, that's going to open up a whole other area for us to look at. Okay, and next slide, please. I think that's my last slide. Yeah, so this is just who I want to thank for everything, all my collaborators and colleagues and people in my lab. And then I did go into the ADRD summit recommendations to try to link this up, and it was going to be very difficult. The one thing I will say is that the number 1 or 2 recommendation from every single subcommittee on that summit is biomarkers, whether it's the vascular, the TDP, the Lewy body, everybody. And it knows that biomarkers is probably the most important thing we need to get right now. So thank you all.
All right, fantastic presentation. And I think we all recognize biomarkers are the essential step. It's the path to success. So we have to go through there. It's exciting new biomarkers. I don't know if there are any questions or comments from the group. We're running a little bit behind, and I'd like to give people a brief break before public comments. Sorry, was there a question, Helen?
You know, you covered quite a bit with existing, right? I mean, but it was fabulous. But I'm wondering, when we talk about inflammation, I've been doing a lot of reading around the inflammation in COVID-19. So, you know, there are studies, I realize, that are just beginning when it comes to that. But do you have any comment in general about how that might be moving forward, what we can look for in the future in that area?
To clarify, in the area of COVID or just generally inflammation and biomarkers? Yeah, so I think where it's valuable to look is in when we think about acute inflammation, when we think about infection like COVID, usually you'll see, and I think a lot of us became familiar with the term cytokine storm, right, when COVID was happening. You see an acute increase in a lot of these cytokines that were on, you know, the candidate biomarker figure that I showed. And then there's a resolution stage. In diseases like Alzheimer's and other chronic neurodegenerative conditions, what we see is that there's almost an apparent burnout of a lot of these systems because of the chronic nature of these. I've heard microglial exhaustion being talked about. And so I think we'll see multiple inflammatory biomarkers, and the utility of those is going to depend on, so for instance, let's say we start to see some of these new TNF modulators having efficacy on clinical function. Now TNF alpha might be a biomarker that we measure to know whether someone has elevated TNF alpha and would benefit from one of these drugs. I think for drugs like donanemab and lecanemab and aducanumab, where all of those actually do rely on an inflammatory response to get rid of the plaques. And so it may be something like soluble TREM2 or IL-1 beta or even GFAP could be an indicator of whose immune system is primed so that they might benefit more from these drugs than other drugs. I think we're going to see inflammatory biomarkers being used when we have therapies that use that system and manipulate that system.
Okay, great. And with that, we're all going to take a 5-minute break before public comments and start promptly in 5 minutes.
Produced by the U.S. Department of Health and Human Services.